Hi, my name is Marissa Mitchell, and I'm a speech-language pathologist and researcher in the Department of Developmental Medicine at Geisinger. Thank you for inviting me to participate in MED13L Day. I'm excited to share with you some recent research findings on speech impairments in MED13L syndrome. So to begin, I'll give an explanation of pediatric motor speech disorders, including what they are and how they're diagnosed. Then I'll discuss what speech research our study team has recently completed and is currently working on. Lastly, I'll spend most of our time today describing what we know about the speech and language features associated with MED13L syndrome and the clinical implications of these findings. So first, what are motor speech disorders? Before I explain what motor speech disorders are, it's important to have an idea of how speech happens in the first place. So for most of us, speech is automatic. We don't have to think about the steps that are required to produce fluent speech. But the reality is that speech is an incredibly complex enterprise. First is the cognitive linguistic stage, so right here, where you decide to communicate and formulate the message in your head. Next is transcoding, when you need to plan and program the sequence of motor movements needed to produce sequences of sounds. After this is the execution of the motor plan. So this is where the lips, tongue, jaw, palate, and respiratory system must work in concert to produce fluent speech. And lastly, you process the sensory feedback stemming from speech production and reflect on how it sounded and how it felt. This helps you fine-tune the accuracy and precision of speech over time. When you realize how much goes into producing speech, it's no surprise that there are many ways where speech can break down. Speech sound disorders, or problems with speech clarity, are the most common childhood communication disorders. They affect up to 5% of children ages 3 to 17. However, pediatric motor speech disorders make up a small percentage of these, so fewer than about 1 out of 5 cases of speech delay are caused by motor speech impairment. So speech problems fall on a continuum depending on where the deficit occurs. On one end of the spectrum over here, you have anatomic problems. These are things like cleft palate or hearing impairment that impact a child's ability to speak clearly. On the other end of the spectrum are higher order cognitive linguistic problems that involve misclassification of entire phoneme groups. Motor speech disorders impact either motor planning and programming or execution. Most speech sound disorders resolve in childhood spontaneously or with low intensity therapy. In contrast, pediatric motor speech disorders often require years of intensive specialized speech therapy to improve intelligibility, and some kids are never able to achieve completely intelligible speech. We can define motor speech disorders as speech impairments caused by deficits in motor planning and programming, which results in childhood apraxia of speech, or motor execution, which results in dysarthria. Childhood apraxia and dysarthria commonly co-occur with each other, and they can be difficult to correctly diagnose, even for experienced clinicians, because there are a lot of overlapping features, things like vowel and consonant distortions, voicing errors, slow speaking rate, fluctuating resonance, and dysprosody. Although articulation problems are really common in early childhood, so about 5% of all children, motor speech disorders are relatively rare. They have an estimated population prevalence of only about 1 in 1,000 kids. Motor speech disorders most often co-occur with other neurodevelopmental disorders. In fact, the majority of children with apraxia or dysarthria also have broader problems with language, cognition, and behavior. Isolated cases of pediatric motor speech disorders do occur, but these are actually quite rare. With this in mind, I want to briefly describe the methods that we've used to investigate the presence of possible motor speech disorders among individuals with MED13L syndrome. I first became interested in MED13L syndrome when our research team identified 6 children who had variants in MED13L in a large cohort of children with motor speech disorders. It was actually one of the top 20 most frequent genes that we identified out of over 200 genes. As a result, I wanted to directly measure the speech and language skills of children who had been previously diagnosed with MED13L syndrome, but maybe had never been evaluated for a motor speech disorder. The findings that I'll discuss today are based on two groups of participants. The first group consists mainly of children and adolescents with MED13L syndrome who attended a large family conference hosted by Simon Searchlight that took place back in 2022, along with one additional child who we follow clinically here at Geisinger. This data was published earlier this year in the Journal of Neurodevelopmental Disorders, and it's freely available to the public. Data from the second group of 10 children was actually just collected this summer at the MED13L conference in Boston. These data are preliminary and we're still analyzing it, but I did want to present what we know so far to you today. So the children enrolled in our study met with both me and my colleague, Dr. Cora Taylor, who's a pediatric psychologist here at Geisinger. They completed a number of standardized and dynamic assessments that measure several domains, including speech, language, motor skills, and cognitive skills. The entire test battery takes about 1 to 2 hours depending on what the child's able to complete. So while I'm most interested in pediatric motor speech disorders, it's important to understand speech in the context of overall development across language and non-language domains. So before moving on, I do want to explain the difference between what I mean with speech and language. I think in everyday life, we hear these words are used interchangeably, but in the field of speech pathology, we do make a distinction between speech and language because they can be affected in different ways. So language refers to the abstract, rule-based system of meaning, structure, and pragmatic properties of words, whereas speech is the spoken modality of language. So it requires physical movements and coordination. Because of this, there's a motor component to speech that needs to be considered. So what have we learned based on this research? First, most of the children who enrolled in our study had at least some speech, although a few children remained minimally verbal, and we define minimally verbal here as fewer than 10 words. Among the remaining children, a little over half spoke mainly in single words and short phrases. A sizable minority did speak in complete sentences and could have a conversation with another person. The most striking finding was that all the verbal children we tested met diagnostic criteria for at least one motor speech disorder. So 12 had apraxia, 2 had dysarthria, and 10 actually met diagnostic criteria for both apraxia and dysarthria. The universal nature of motor speech impairment among children with MED13L is really quite unexpected given the rarity of pediatric motor speech disorders in general. So if you remember earlier, these occur in approximately 1 in 1,000 children in the general population. So the prevalence of it among kids with MED13L really shows that motor speech impairment is a core feature of MED13L syndrome. The degree of speech impairment varied significantly between kids from mild to severe, and while it's difficult to measure the severity of motor speech impairment in a quantitative way, our most recent study did ask families to estimate the speech intelligibility of their children. On average, they reported that familiar partners understood about 80% of their kids' speech, while unfamiliar partners understood considerably less, so less than half on average. Similarly, there was significant variability in developmental milestones. On average, parents reported that their kids spoke their first words right around the time they turned 2, but first words were reported as early as 11 months and as late as 36 months. For about half of the kids who were combining words at the time of the study, phrase-level speech was achieved at an average age of 43 months, so just shy of 4 years. But this also varied considerably, with one child using simple phrases as early as 13 months, and one child didn't speak in phrases until they were 6 years old. So many kids who have motor speech impairments also have difficulty with non-speech oral motor skills, so we wanted to capture impairment in that area as well. More than half of the families reported some degree of oral motor dysfunction. For some, this was mild and included things like difficulty breastfeeding in infancy, which typically resolved by early childhood. But other kids had more significant challenges and demonstrated swallowing problems, choking, and aspiration of liquids into the lungs. A few children needed G-tubes for nutrition as a result. Many kids have low muscle tone in their face, which can lead to drooling and an open mouth at rest. And one parent reported that their child was diagnosed with something called laryngomalacia, which is a condition where the tissues that surround the voice box are floppy and can collapse during breathing. Next, we asked families about their children's use of augmentative and alternative communication, or AAC for short. AAC refers to tools and strategies that supplement or replace a child's speech when it's not sufficient to meet their daily needs. Kids benefit from AAC when they don't use many verbal words or when the speech they do use is very difficult to understand, as is the case for many children with MED13L. AAC includes high-tech strategies like speech-generating devices, as well as low-tech strategies like sign language and pictures. More than half of the kids in our study use some form of AAC at some point in their lives. Typically, kids would start out with sign language really early, so usually before 2 years of age, and then they transition to a speech-generating device after about the age of 2. The most common device that children used in our study was the iPad with a communication app. Next, I'll talk about language, cognitive, and motor testing that we did. The kids in our study completed standardized tests in all of these domains. The tests that we administered report standard scores. When we talk about standard scores, the average is 100, and we usually say the average range is 85 to 115. So on average, kids in our study scored below the average range across all areas that we tested, although there was variability where a few kids scored in the low average or borderline range in visual motor skills and nonverbal cognition. Language skills were more significantly impaired, without much of a difference between receptive and expressive language. So that means that most kids had equally impaired comprehension as well as production of language. And then for those children who are able to complete an IQ test, nonverbal IQ was generally higher than verbal IQ. In addition to visual motor testing, we interviewed caregivers to determine how motor skills may be impaired for their children. They reported a number of motor diagnoses that had been assigned in the past. By far, the most common motor feature was hypotonia, which means low muscle tone. This affected almost all children to some degree and was most often diagnosed in infancy. The second most common motor diagnosis was ataxia, which was reported in half of all children. Ataxia refers to impaired muscle control that leads to poor balance and coordination problems. Ataxia is usually caused by damage to a part of the brain called the cerebellum. And interestingly, there's some research that shows that MED13L is highly expressed in the cerebellum. More research is needed to see how MED13L gene expression might impact motor function, both globally and in the context of motor speech disorders. A minority of children were diagnosed with dystonia, hypertonia, which is actually high muscle tone, or cerebral palsy. So to summarize our main findings, all verbal individuals who completed speech testing met diagnostic criteria for at least one motor speech disorder, so apraxia, dysarthria, or both. In addition to speech impairment, children exhibited universally impaired language skills with similar performance across receptive and expressive tests. Children typically exhibited an intellectual disability, but with a relative strength in the area of nonverbal cognition. And lastly, most children exhibited globally impaired motor skills. So these findings have direct clinical implications for children with MED13L syndrome. First, children would benefit from early referrals to speech therapy if they're not already receiving it at the time of their diagnosis. Speech-language pathologists should have a low suspicion for a diagnosis of apraxia or dysarthria, even if the child isn't yet producing much speech. Research shows that early intervention using evidence-based motor learning techniques are beneficial for kids with motor speech disorders, so these should be implemented as early as possible and at a high intensity. Lastly, many children in our study benefited from AAC strategies, whether these are low-tech or high-tech. Speech-generating devices like iPads with communication apps were often used successfully and helped improve children's functional communication skills. So these should be explored for children who aren't yet using much speech or when their speech is difficult to understand. So thank you so much for inviting me to join you today. I also want to thank all those families who have participated in our studies. This research wouldn't be possible without you.